Yes. So now Tejas, can you hear me?
Yes.
So we have to
Wait for
prepare
one.
parents for future interventions, because if a child is having avulsion injury, we have to operate them for 6 to 8 hours. So these are major surgery for young babies, and so we have to prepare them. And so if we find the signs of early intervention, we have to counsel them from day one. And again, we have to prevent development of early contracture. Now the question is, what are the markers? So just a moment, I'll share my screen again. Yeah, they just can see now. You can see the screen now,
The
Tejas?
display is not showing.
Yes.
Can we
What
see,
are the
sir?
Yes, sir, we
markers
can see.
pointing to early nerve surgery? The first and foremost is when a child is not opening one of the eyelids completely, that's known as Horner syndrome. And this is a sign of root avulsion injury, which we see in the lower trunk avulsions. And this is a sign which suggests that this child would need a early nerve surgery at the age of 3-4 months. The second sign is a completely flail limb. When a child's limb remains flail from 2 months onwards to 4-5 months, that is again a sign that this child would need a early nerve surgery. Some children are very tachypnic, they are perspiring, and they have failure to thrive. Their weight is not increasing. They might have hemidiaphragm paralysis, which is a sign of phrenic nerve palsy, and this shows the upper trunk avulsion. So this is again a marker which gives clue about need of early nerve surgery. Now this is a 7-year-old boy where at the age of 4 months we advised surgery, and some physiotherapy colleagues said that most of these patients recover, and you can see he does not have any deltoid power, he does not have any elbow flexion, and he does not have active wrist extension. So this happens if we do not intervene them in time. And in contrast to that, look at this girl. This is a 4-month-old baby who had 4 kilogram of body weight, and she had panplexopathy with Horner syndrome. The MRI also suggested that she had C7, 8, and T1 avulsion injuries, and there was neuroma in C5, 6. And we performed the neuroma excision and sural nerve cable grafting between the existing nerve roots and the lower trunk, and we also performed the neurotization of nerves. And this girl is now 7 years old. RV is 7 years old, and you have to compare RV to the previous boy. Look at her global shoulder abduction. Look at her hand to neck motion. She had good range of hand to spine. She has good range of shoulder internal rotation. Her global external rotation has also improved, and her hand function is also moderate. So she required, after primary nerve surgery, she required few tendon transfers. But you can compare RV's outcome to the previous fellow who is not able to abduct the limb at all. So this change you can make by referring patients well in time. Now, those patients who are recovering, the important thing is to measure passive external rotation of shoulder, because many kids, they develop, so many kids tend to develop uh, shoulder internal rotation contracture, and that is measured by turning the arm out by keeping the arm adducted. And when the passive external rotation reduces less than 40 degrees, it is alarming, and one should consider some intervention, because when it goes less than 40 degrees, there are chances that that shoulder joint started subluxating posteriorly. Now let's take few cases and you will understand. There's a 6 months old baby, was diagnosed as Naracast 1. And the therapist found recent reduction in the range of passive external rotation from 80 degrees to 50 degrees. And here we do not do some surgery, but we intensify the therapy and we do more task oriented active motion. We do hold and relax techniques. We do stretching in suboptimal maximum range to increase or stretch the tight internal rotators. And we also use sometimes night splinting, like this aeroplane splint. And in some very young children with present with shoulder subluxation at 2 months, we use what is known as super splint, which keeps the extremity in supination and external rotation. And that had helped us in preventing early contractures in few patients. Now let's see at this baby which is 4 months old, and her passive external rotation has reduced to minus 20 degrees. So it's a very significant internal rotation contracture, and patient has persistent internal rotation posture. The therapy has become difficult and very painful. That's why patient was referred to us at early. You have a look at the baby. You can see a very deep anterior crease at the axilla. The arm is persistently internally rotated, and any attempt in turning the arm outward is very painful. Child starts crying, and the arm segment looks shorter compared to the other side. So these are the signs which suggest that this child is having infantile dislocation. So these are the red flags that the shoulder joint is getting dislocated behind. One is passive external rotation when it reduces below 0 degrees. When there is deep anterior crease, the arm is short and there is non-use. So these are the signs of infantile dislocation, and you have to intervene immediately. If you just keep on stretching these shoulders, you will produce flattening of cartilage of glenoid and the humerus. If you do an ultrasound, you can see the whole humeral head is lying behind the scapula. So this is a posterior dislocation of the shoulder joint. One of such children, here we have to consider Botox injection, and under anesthesia we have to stretch them. This is the pre-anesthesia, pre-Botox and stretching external rotation. This is at the end of procedure, and we have to apply a shoulder spica. So that's what we do earlier on. Now this is the third case, and this is a bit grown-up child who has not very severe contracture, but she is 11-month-old baby now, and passive external rotation is only 20 degrees. Her posture is internal rotated, and her abduction and external rotation is limited. So again, by this time, the child should achieve some degrees of abduction and external rotation. So therapist referred this patient to us, and you can see the child can abduct to 90 degrees, but her arm posture is persistently internally rotated, and she has internal rotation contracture. So in those cases, we do Botox injection in subscapularis and pec major, and we take away the imbalance between the muscle, and recovering muscle would start functioning and child would improve. So this happens in children where there is already recruitment in external rotators and abductors, but because of tight internal rotators, they are not showing improvement, or there is a co-contraction between muscles, and physiotherapists help identifying those co-contractions and refer them to us. Now let's take this interesting child, 2-year-old boy, who is having persistently internally rotated arm, again difficulty in elevation, and when they try to reach mouth, they lift their arm because of internal rotation contracture, or what is termed as trumpeting. And because of this posture, his use of that limb is very limited. Now look at this child, a slow-mo video. The arm is internally rotated, elbow is pointing outwards. The motion of the child is in abnormal plane, so he has to take help of other limb to reach to mouth. It's very difficult to reach to mouth. The way he holds object is also pretty abnormal, and if you give something to hold, he uses the trunk, lifts the limb, but he is not able to reach in the center. So the position of the extremity in space is very abnormal. So these patients which are grown up, we do MRI scan to see, and clinically we use modify Mallet score. Now Mallet score is a 5-grade score which denotes the global shoulder function. It shows global abduction, global external rotation, hand to neck, hand to spine and hand to mouth movement. And each grade is ranging from 1 to 5, where 1 is no movement and 5 is normal movement. So this again, this is a nice score. We can use it an outcome measure, and we should plot it. Or when a therapist refer to me, they give that this modified Mallet score of this particular child is this much. So let's see what score this boy had. He had global abduction was 90 degrees, so it was 3. External rotation was less than 0 to 2. He could not reach behind the neck, so it was 2. Hand to spine, he could reach to S1, so 3. And he had
number 11
so his aggregate Mallet score was 12 out of 25. And his MRI, if you can see, the preoperative MRI, he has dislocated the type 4 water. So the shoulder was dislocated behind and there was pseudoglenoid formation. So we perform what's known as minimally invasive subscapularis release and tendon transfer. And this is a novel technique developed in CBPC at OrthoKids Clinic. And you can see the outcome of this baby now after surgery and compare with the preoperative. His abduction is substantially improved. His full abduction this boy has gained, where it was limited to only 90 degrees. His external rotation is full, which he used to keep in persistently internally rotated posture. He could reach to the midline nicely, as you can see. And his active external rotation is also substantial. So with the internal rotator release and tendon transfer, you get good external rotation, and he still can reach behind the spine. So this is the these are the group of patients where physiotherapists should identify that there is no role. After 1.5 years, natural recovery stops, and you have to take help of some surgical intervention. And so the therapist should refer those patients to the brachial plexus surgeon. And after surgery, they have to devise a combination of task-oriented exercises, home-based strategies to improve movement, to activate the transfer tendon, to do motor relearning of transfer tendon, and so on, to improvise their function and to improvise their Mallet score. So if we look at this boy, his Mallet score, which was 12 to start with, after surgery, it has improved to 18. So this is the place where the therapist's role comes to play. Tejas, our pediatric therapists, have taken help of aquatherapy to provide some weight bearing in the water, and that has also found helpful in some of our patients. So I will stop there in terms of case discussion. I would like to summarize what is the role of physios in treatment. The first and foremost is to diagnose that this is Erb's palsy and differentiate from the pseudoparalysis or pseudo-Erb's palsy, whether it's a fracture or infection or something else. So that is the first role of physiotherapist. The second is you classify them both from anatomic perspective at the same time within Naraka's grade, and identify the one which needs urgent intervention. So those with root avulsion or Horner syndrome, hemidiaphragm paralysis or flaccid limb for 3 to 4 months, these are the ones which need urgent nerve surgery, and that should be referred earlier. The third is assess the progress. Once the child is recovering, you just can't say that your child is doing good, but you learn how to plot the quantification of their improvement on a hospital for sick children active movement scale, so that you can make the family happy that my child is improving. Now, those you have children at home, you will be happy to receive their progress report. Similarly, parents will be happy to see the progress of their child in terms of scoring. So HSCMS is very important. The fourth thing is prevent contractures. Therapist's role is not only to stretch it, but have to identify the early contracture formation. When you find contractures are happening, you can induce extensive therapy, stretching, and you can also give some splinting, which would help contractures to happen. And finally, once the patient undergone some surgical intervention, you have to create strategies for better activities. Many times these patients, you have to create a role play at home to carry out some task oriented activities. Each child is different, and you have to understand this the psyche of that family, the psyche of that child, to optimize the therapy. So that's the role of physiotherapists in nutshell. See, each child tells us that, see, I'm here with you. You make us, you bring me out of this disability. Now, this 1 year and 18 days old Parth, who presented to our clinic way back, and he's 18 years old now. He underwent multiple nerve surgeries. He underwent multiple tendon transfers. He underwent wrist fusion, and he is here now at 18 years. He is showing he can do all the domestic activities. He can help his family. He can go outdoors. He can ride a vehicle. So our goal is to make an infant with brachial plexus birth palsy to an active, independent adult. That is a goal of all of us. And it's not job of one person. It's not job of just a pediatric orthopedic surgeon. We have to combinedly work with plastic surgeons, hand surgeons, pediatric physiotherapists. And with this idea, we started a comprehensive brachial plexus clinic at our center in 2009. Of course, this I learned from SICKIs, where I was trained, and a team of consultants meet on a specific day of a month, and parents were enrolled. And we are proud to say that about 700 children of brachial plexus birth palsy has been enrolled in this clinic. And we combinedly assess them, cater them, and give our opinion and treat them. And that gives a good satisfaction from our part, at the same time on parental part. So I would conclude my talk by saying that, as our Prime Minister Narendra Modi said, when you work alone, so A square plus B square will be just A and B square. But when you combine this A plus B, it will give you the power of extra 2AB, and that is the strength of comprehensive a clinic. So I suggest you to partner with your specialist and make a team to identify and treat these patients, and that will go a long way in the treatment of brachial plexus birth palsy patients. So thank you very much, and I hope you you gained something out of this talk, and let's make this session open for question answer. So please put your questions in your chat box or raise your hand, and Tejas will let you talk about your question.
So anybody having any questions? It was very nice explanation about the brachial plexus injury, anatomy, and therapy protocol. Participants, do you have any questions?
So any question, Tejas?
So far, sir, which age? So this is question from Dr. Komara Puro Babu. The question is,
Yes.
Which age is preferable? 0 to 9 months? Can we do physio? So basically, he wants to ask till till what age we can do the physio?
Yeah, till what?
till what age we can do the
I can't
physiotherapy?
hear you. Sorry.
Can you hear me?
Yes, tell me now.
Yeah. The question is from Dr.
Tejas, I can't
Kumara
hear
Pudu.
you.
Can you hear me?
Yes, be a little louder.
Yeah. The question is, till how many age we can do the physio? Is 0 to 9 months is ideal age to do physio?
Yeah, so physio should be started. The first assessment should be done as soon as after the birth, and before 6 weeks, we do not advocate regular physiotherapy sessions, but we teach the home program to the families. From 6 weeks onwards, we recommend regular physiotherapy till the complete improvement in children, and then it starts with electrical stimulation, followed by range of motion exercises. Uh, then comes the prevention of contracture, and then as the child starts following some the voluntary commands or visual commands, you can do the task oriented exercises. So therapy should be on not till just 9 months, but even later than that if the recovery is incomplete. And the role of therapy is more important once we perform some surgeries or when some intervention is done. The, let's say, like when we do the Botox, so after relaxing the tight internal rotators and adductors, we have to perform strengthening exercises of external rotators and abductors, task oriented exercises for them. And when we do tendon transfer, then you also have to work on motor relearning. You have to stabilize the joints and provide. So the therapist's role is very important, and it is not time bound. Now, if a child undergoes some wrist fusion operation at the age of 16 years, then I would ask them to undergo some therapy sessions even at the age of 16 years. So the role of therapist is not limited to a few months, but I would say many years.
So the question from the same participants.
Yes, Tejas, please be louder. I cannot hear you.
Yeah. Can you hear me now?
Yes, please be closer to your microphone. Yeah.
Yeah. The question is from same participants, that is dry needling.
Sorry, Tejas, I could not hear you.
Just a minute. I use my microphone.
Yes, that will be good. Please use your microphone.
Can you hear me now?
Yes.
Okay. The question is from same participants that do the dry needling is having a role of brachial plexus?
I could not hear you. Tejas, your voice breaks, unfortunately. So there's some problem with your mic.
Yeah. Can you hear me?
Yeah.
Yeah. The question is, does dry needling is having any role in a brachial plexus injury?
Tejas, again, it goes off when you start. So can
other participants can hear my voice.
I cannot. So just ask your question quickly.
Yeah. So
yes, Tejas, go ahead.
yeah. So the question is,
okay. So I'll take it from my chat box. Doctor, working here. Yeah, unfortunately, I cannot hear Tejas's question. Yeah, so one question is from Dr. Rashmika Rathod is, as I mentioned that electrical stimulation interrupts the regeneration of nerves, from which age we can start electrical stimulation? So the role of electrical stimulation has been controversial. There is no clear-cut evidence that electrical stimulation positively affects the outcome. but we have seen that it helps in maintaining muscle bulk and muscle properties better. So we have been using this, and a few more centers across the globe, they use it, like in Cincinnati and in some centers in US. So we start using electrical stimulation after 2 months. So till 2 months, we do not advocate, because then the process of neuronal regeneration is going on. So we avoid using that. Okay. So any further question?
Yeah. The
Yes.
one more question is,
Question we can put it on, take it on the chat box. I think I can see from there. Tejas.
yeah. So earlier, the one question was, we can see the spine curve at the age of 2 years. So do you recommend any treatment for the spine curve?
So spine curvature means child is retracting on a side to carry out some motion, and that curvature is secondary in as far as the Erb's palsy is concerned. That's not a primary deformity. So as soon as child has more free range of motion at the shoulder, they will kind of tilt less. So that spinal curvature does not need treatment, but you have to fix the spine and stimulate the isolated movement of the glenohumeral joint, and that would help reducing the spinal curvature. So spinal curvature is child is using the torso to move to carry out certain degrees of motion. So once the child develops more free glenohumeral joint, there will be less tilting. So that does not need a separate treatment, but to stimulate more isolated motion.
The next question is there any role of dry needling? So as far as my knowledge, we have not explored dry needling for the brachial plexus rehabilitation. So I would like to have any article related to dry needling in brachial plexus. We would like to hear, and we would like to go through that article, and we may explore that idea. So far we have not used a dry needling, or we have not thought about dry needling yet in
So
brachial plexus.
dry needling, I have been to different centers across the world, and we have heard about this sometime, but there is no positive effect on improvement. So people are not using dry needling in most of the centers across the world. Yes. Any further question, Tejas?
No.
So any participant who want to ask question, raise the hand and we can unmute you and you can ask the question. So if there is no further question,
Yeah, there is one.
then I think
Okay.
Dr. Koma, Kumar, they want to know about the splints. So Tejas, can you talk about splints to them? What sort of splints we use routinely?
Yeah. So we use a different kind of the splints. If we'll start from the aeroplane splint, we typically maintain the shoulder into abduction. Hello, who is unmute? Please mute yourself. Arzu Patel, can you mute yourself? Okay, so if I'll talk about the splints, So first splint is aeroplane splint, which maintains shoulder into abduction, external rotation, elbow into flexion, and forearm into supination, and wrist into a little bit of extension position. Now the range of the abduction and external rotation is depend the availability of the passive range of the motion at the shoulder, and we can modify from 45 degree to 60 degree of external rotation as well as the abduction. For elbow, we use a push elbow splint, which prevents the biceps contracture. For the wrist, we use a cock-up splint, which maintain the wrist into extension position. We also use a paddy reps. Paddy reps has a two role. The first role is which maintains the elbow into extension, and the second role is we help paddy reps to strengthen the deltoid with the elbow extension, especially in the subtype of C5, C6, 7. We use also a night splints, which maintain hand into typically elbow extension, supination, and wrist into extension. Anything else you want to add, sir?
So someone asked that is aeroplane splint available for young children? Yes, it is available, and it can be customized, and it's available in all the sizes. So this can be very easily made, and we are orthotists. They are very trained to make this. So if there is no further any other question from any, there's one more in chat box. So let's see what is it.
We can use super splints also. The one which Dr. Maulin has explained, which maintain the shoulder external rotation and elbow into extension, and full, which prevents the internal rotation contraction.
So Tejas, if we are have enough question, I think I will unmute Dr. Mukesh to make the final comments, and we can conclude this meeting. So Mukesh or Peenal, you can unmute yourself, and you can conclude today's meeting. If you have any further questions or query, please feel free to communicate with me or Tejas, and we'll be happy to answer all the queries. So the Mukesh,
can you am I audible, sir?
Yes, Mukesh bhai, you are audible.
Am I audible, sir?
Yes.
Thank you so much, Dr. Maulin sir. It is a great opportunity for Mehsana Physiotherapy Association to have such your type of lecturer, and we heard we had a maximum type of education from you, and thank you so much, sir, and thank you, Tejas bhai, for sharing your valuable memories to us. And hello.
Yes.
Hello.
Yes, Mukesh, we can hear you.
Yeah. Thank you so much, everyone who has participated for today's webinar.
Thank you very much for having us here, and we would like to conclude. Everyone, thanks for your time, and we'll be happy to answer any question if we meet in future, or if you have any question, you can inquire with me or Tejas. Take care. Now, Rashmika
Sure,
is
sir. Thank you so much, sir.
Proximal muscles get faster recover than fine motors in these patients. I think it's the other way around. The recovery is from distal to proximal, and that depends on what type of injury it is. So now this is just a flavor of what we do. You know, we conduct the whole day workshop, and I hope this Corona time resolves very soon, and we can conduct one day workshop. We have done one at Mehsana before, and I remember about 75 physiotherapists participated in that meeting. So maybe in near future, next year, we'll arrange one more workshop and you come, and that's a one full day of education, and that will I mean, make you more aware about the subject. We also have some of therapists or occupational therapists and some surgeons observing us in our clinics. So we have this comprehensive clinic every third Friday. So in one of the clinics, if you are interested, you can communicate with me or Tejas, and we will have you here, and that will give you a lot of exposure to these patients. We have usually 25 to 30 patients of brachial plexus palsy in one day, and that there's different variety, different follow-up of operations. So that will guide you to the subject. So I invite any one of you, if you wish to come and join us in our clinic as an observer, you're most welcome. And hopefully this corona time disappears very quickly and we are back on track again. Okay, take care. So I'm ending the meeting. Thanks Mukesh again and Peenal for your arrangement. And I hope this talk was useful to everyone. Bye-bye. Thank you, Tejas.
Yeah, my pleasure. Bye. Good night.
Bye. Take care.